Greetings, everybody. This is Steve Cole with your PARM 2223 lecture coming at you for Unit 13. That's Unit 13. Okay, so what we're going to do is we're going to talk about, well, I guess it'll be apparent what we're going to talk about. The title of this lecture is called A Storm is Coming, and the reason is we're going to talk about primary and secondary hypothyroidism. We're going to talk about the extension of that, Graves' disorder, and thyroid storms. And we're going to talk about optimal treatment. So when we're talking about hypothyroidism, what we're talking about is various conditions that affect the production of thyroid hormones, both the excretion and the circulating levels, and all the adverse effects. So the thyroid hormone is considered one of the most important, or thyroid gland is considered one of the most important endocrine glands in the whole human body. That, along with the pituitary, which the pituitary gland used to be called the master gland or the master hormone. However, there's some debate now whether the thyroid may actually have a more prominent role. And without getting too much into the endocrine system and getting completely off topic, but you should know that the thyroid gland itself exists right behind the cricothyroid membrane, and that cradling each side and behind it, and with a little tiny stretch right in front of it called the thyroid isthmus. And what's interesting, I'm going to see if I can point out the thyroid isthmus here, just to bring out right through there is the thyroid isthmus. And what's interesting to me when we talk about that, just to tie it into other parts of your education, unrelated hypothyroidism, is that if you have an extensive amount of bleeding when you do a surgical cricothyrotomy, it's most likely because you nicked the thyroid isthmus. It will bleed like a stuck pig because it's very, very well perfused. But that's neither here nor there. So we're going to talk about hyperthyroidism, which is a wide variety of conditions that cause the overproduction of thyroid hormone or the increased circulating levels of thyroid hormone. There's a couple of different ways that occurs. Thyrotoxicosis is very similar to hyperthyroidism, results in the same thing, but it's from conditions outside of the thyroid gland itself. Technically, depending on the definition you look at, some people would say that hypothyroidism is a form of thyrotoxicosis, but not all thyrotoxicosis is hyperthyroidism. Thyroid storm is the crisis manifestation of hyperthyroidism or thyrotoxicosis. And it's life-threatening. It has up to a 20% mortality, depending on which text you read. And it's it's almost like a sympathetic syndrome. In some ways, not always, but in some ways similar to what you'd see with overingestion of methamphetamine and other stimulants. Now, the nice thing about most hypothyroidic states is that they can be managed chronically and managed very well with a minimal of side effects. But when they're poorly managed, when they're neglected, so on and so forth, is when things go sideways. Now, when we talk about hyperthyroidism or thyrotoxicosis, it's not a single problem, but kind of a constellation of symptoms across multiple organs. It affects the liver, it affects the renal system, affects the hepatic system, affects the GI system, affects respiratory and cardiovascular system. Very, very bad news. Now, the good news is that incidence is a lot lower in the United States compared to even other westernized countries, particularly Asian countries. And the reason is because we're big fat Americans who love salt on everything, particularly iodized salt, which is very common in the United States. Most people don't think about the salt they put on their food or they use in cooking as iodized salt, but that means it has supplemental iodide. Compared to in Asian countries that don't use a lot of salt, and the salt they use typically is not iodized, they are often iodine deficient, depending on their diet. So, for example, in Japan, hypothyroidism exists in up to 10% of the population, compared to 1 to 4% in the United States. Now, Japan has a very well-developed healthcare system, etc., but one of the key things is they don't have the same amount of dietary iodine in their diet compared to Americans. So it's the one benefit I have from being in the South is I probably will never suffer from lack of iodine with all the southern foods I eat. But anyway, so moving right along. There's an example now. When we talk about hyperthyroidism, the thyroid itself can often be engorged and can become displaced, and this sometimes can be palpable, although not always. We kind of break down hyperthyroidism and thyrotoxicosis as primary and secondary. Primary hyperthyroidism is caused by excessive production of thyroid hormones from the thyroid gland itself. Something, whatever that cause is, we'll talk about it, is causing excessive excretion. Secondary hyperthyroidism is caused by production of the hormones that stimulate production of thyroid hormones, TSHs, and these come from the hypothalamus and pituitary glands. So to give an example, there are cancers that invade the thyroid gland itself, and these are some of the other causes that can cause primary hyperthyroidism. But there's also pituitary cancers that can indirectly cause the same thing. There's also an autoimmune disease called Graves' disease that we'll talk about in a few minutes. That can also cause, it's considered a primary hyperthyroidism because the autoimmune response actually causes the thyroid gland to produce more thyroid hormone. There's also ectopic thyroid tissue, and this is kind of a cancerous, pseudo-cancerous condition. I won't claim to be an expert in this by any stretch of the imagination, where you have thyroid tissue other than in the thyroid gland. And I saw one case study of thyroid tissue looking like a mole, and various and thyroid tissue just popping up other places. It's kind of a weird idiosyncratic mutation. And of course, there's toxicological causes, which we'll talk about in a few minutes. In about 20 to 25% of cases, which I found really startling, they couldn't identify the precipitate cause, but they just knew that they had hypothyroidism in some cause, or in some form or another. So that was really interesting to me. So let's delve a little bit deeper into this. When we look at toxicological causes, I specifically wanted to pay attention to, we talk about amiodarone. Amiodarone actually has content which can increase the iodine intake, and increasing iodine can also affect the activity of the thyroid. Thyroxine overdoses, so people who overdose on synthroid and levothyroxine. Radioactive, there's also cases of people actually developing transient hyperthyroidism after iodine from CT with contrast, i.e. like CT angiograms. And sometimes people who are coming off thyroid blocker medication, so they've had a previous severe episode of hyperthyroidism, they decrease or eliminate the thyroid blocking drugs, and then they have a withdrawal syndrome that causes a thyroid storm itself. Now, of particular note is something called Graves' disease. Now, Graves' disease, this is Robert Graves, who first described it in 1835. That was his moment of fame. And he looks a little bit like he might have it himself, honestly, but that's just the image. Graves' disease is an autoimmune disorder, and it leads to a generalized overactivity of the entire thyroid gland, which, in essence, the immune response, the antibodies attach themselves to the thyroid gland itself and causes it to become inflamed and overproduce the thyroid hormone, and this causes hyperthyroidism. This is the most common cause of hyperthyroidism in the United States, and it's also the most common cause of severe hypothyroidism, aka the thyroid storm. So if you're trying to determine if they might have a thyroid storm or not, it is not absolute, but it really tilts you toward thyroid storm as opposed to other causes that they have a history of Graves' disease. And it is a hyperthyroidic condition, so its symptoms are similar to hyperthyroidism as a whole. However, it's a specific subset. So let's talk about these symptoms for a minute. And you can find them broken down in lots of different ways, but I tried to kind of organize them in kind of categories. So kind of metabolic or constitutional causes. The constitutional causes is one term that was used in one of the studies I was reading that, or one of the papers I was reading that research up on this. And I like constitutional causes because as a role-play gamer myself, I like having characters with a high constitution because it affects their hit points. But that's neither here nor there. We look at that, their constitution, unmitigated weight loss. So weight loss without trying to diet, sometimes weight loss even though they are increasing appetite, increasing caloric intake, they continue to lose weight. Increased appetite. As a result of that, increased resting body temperature, sweating, irregular or absent menstruation, and muscle weakness and fatigue. Sometimes even muscle wasting is on there. There are some behavioral concerns such as nervousness, anxiety, insomnia, psychosis, even in some rare extreme cases, transient paralysis, which is kind of a neuropsychological condition. But what's really concerning for us as paramedics is, of course, when we get into the cardiovascular system, you can have some systolic hypertension. You can actually have resultant hypotension, which I didn't actually put on here, but I should have. These are related to high output heart failure states. So you have a tachycardia, the heart's beating so fast that you get a loss of preload and you get loss of ventricular atrial contribution to the ventricles, which results in incomplete filling of the ventricles and your blood pressure bottoms. But also you can get pulmonary edema and high output heart failure in that regard. A substantial portion of these are atrial fibrillation as far as the tachycardias. So that is, I forgot the exact number, but it's approaching 50%. So it's a new onset of atrial fib with hyperthyroidism is interesting for this. Looking at your physical exam, brittle hair, hair loss. Sometimes you can palpate the thyroid gland. They call this a goiter. You'll see frequent redness around the eyes or even conjunctivitis, almost like pink eye, frequently. And this is particular to, you'll get some irritation of the tissue and the muscles around the eye where they become so inflamed, they will actually cause the eyes to bulge out and the lids will become incompetent. So you get what they call lid lag, where the lids won't close all the way over. This results in the conjunctivitis because the eyes become dry. And they bulge out, and sometimes you'll actually see, I don't think I put it on here, you will actually see patients with acute onset of double vision. And it's because the brain is used to processing the input from the eyes, the data from the eyes to concoct this image that we consider our visual acuity. When the eyes become bulged, it's almost like they become out of calibration, and therefore you have doubling of the vision. And when the inflammation is reduced, the eyes fall back into calibration and their vision returns. You can also have anemia, which can manifest itself in both pale skin, but also falsely elevated SpO2. Because remember, SpO2 measures the hemoglobin that is saturated, not the amount of hemoglobin. So you can have low hematocrit, but normal SpO2s. You can also have liver problems. So you get jaundice of the sclera and jaundice of the skin. And I put a note in here that while increased thyroid gland size and palpable goiter is common, not all of them will have that. Now, there's other things such as GI upset, rashes, particularly lower extremities. I got some pictures of that. It's very particular. And increased sensitivity to heat or cold. So when we talk about thyroid gland enlargement, here's a great example of that. Easily palpable swelling along the lower margin of the neck. Sometimes this is accompanied with tenderness. We already talked about the eye disorders a little bit, where they have this Graves ophthalmopathy or orbitopathy, where they have the bulging eyes, and that's not so much the increased size of the eyes, but the increased inflammation of tissue surrounding it. And if you look here, you may have actually seen this on patients and not attributed to anything other than just getting old or one of those weird skin disorders, but this is very particular. So if we had true congestive heart failure, what you'll see often is swelling of the pedal edema as well, swelling of the feet. But in this case, it's located to the paratibial area, and you have this dry redness, leathery appearance that is also extremely tender of the area as well. And this is particular to hyperthyroidism. And what's really interesting to me, I just want to mention this out, is that the bulging of the eyes is most commonly associated with Graves' disorder as opposed to the other kinds of hyperthyroidism. Give an example, Marty Feldman was a comedic actor who not only had Graves' disorder and bulging eyes, but used it actually to comedic effect in many of his older films. Rodney Dangerfield also had it, and also a comedy. Graves' disorder can't get no respect. Those of you guys who are old enough to remember Rodney Dangerfield, that was one of his common comedic self-depreciating routines, was he couldn't get no respect. Missy Elliott. And I admit, I haven't seen Missy Elliott on the heavy metal circuit very much, but my wife has, and my daughter are very familiar with Missy Elliott's more hip-hop and rap routines. And as they say, Graves, you can read it right there, that's one of her songs. But she also had to take time off of her circuit because she also has Graves' disease, but appears to be managing it very well and is continuing her musical career. Now, speaking of management, let's look at the chronic management and treatment. So we're looking at radioiodine therapy. Now, thyroid blocker medications, beta blockers, and even surgical removal of the thyroid. Now, that's the common kind of family practice endocrinologist treatments. Pre-hospital treatment, I don't know if you can read this very well. I should have increased this. So, basic supportive care, obviously. They're going to get oxygen. They're going to get cardiac monitoring. We want to check their temperature, and the level of fever that they may have is proportional to the severity of their condition in that moment in time. So they can actually get quite febrile, and we'll talk about this. They can be dehydrated due to increased metabolic rate from increased circulating thyroid hormones. So saline is perfectly appropriate for these patients as fluid replacement. Keep in mind, check their lungs first, so on and so forth. Often they'll be, they may also have they may be not diabetic, but they may have some hypoglycemia from the elevated metabolic rate. So therefore, some dextrose may be appropriate. Maybe some dextrose into the IV line and titrated in. Now, especially when this occurs with the instance of alcoholism or other malnutrition, then it may be some thiamine, if you have that in your protocol, may be appropriate. It's one of those low risk, possibly high benefit condition interventions. However, the research or the evidence behind it isn't huge. Therefore, you don't see it as a high priority. Let's talk a little bit about thyroid storms. Now, thyroid storms are rare conditions that are more common in women than men. Incidentally, hyperthyroidism is more common than women than in men. So that's important to note. Extremely rare in children because it tends to, this is a progression disease in children younger. Most cases have Graves' disease as a backdrop to it. So hyperthyroidism can occur with any type of thyrotoxicosis, but most commonly occurs with Graves. Now, here, I want to talk a little bit about some of the leading causes. Other causes I should put there, something called Hashimoto's thyroiditis. So if they have Hashimoto's syndrome, that's also a common cause. Postpartum thyroiditis. So sometimes due to the stress of childbirth, the physiological stress, not just the stress of having a kid, although I'd love to be, go down that pathway, but just the stress of childbirth can throw some patients into a transient hyperthyroidism. They can develop a thyrotoxicosis from that. Toxicological amiodarone can promote thyrotoxicosis, as can thyroid hormones. So they may be on thyroid hormones for hypothyroidism, and then may actually develop they may, due to metabolic changes, may have a cumulative effect. It may be an intentional overdose, an accident, and develop problems from that. And it can also be result from adrenal insufficiencies as well, such as what we see with Addison's disorder. Now, the triggers, you can have triggers for hyperthyroidism and thyroid storms. This can be untreated thyroid disease, such as they're non-compliant with their meds or can't afford them. Trauma. They will actually treat people for this condition going into surgery, because just the act of undergoing surgery can be a precipitant. MIs, infections, that DKA, HHNC, if they are diabetic. And also aspirin overdoses can also be a major cause. Now, the treatment for thyroid storms is largely symptomatic, but I want to point out that thyroid storms are indeed have a very high mortality, up to 20%. So keep this in mind. Most of your presentations of thyroid storms are due to sympathetic surges. So the idea of a storm is a good mental construct for this. So because of sympathetic surge, increased sympathetic tone, you often have fevers, you have tachycardias, you will have altermentation from the fever. As I talked about, atrial fib and high output heart failure, hepatic failure, even seizures, delirium, and coma. Now, what are the mimics for this? Obviously, methamphetamine use or cocaine use is a huge mimic. Sepsis, strokes, particularly strokes of the hypothalamus, near the hypothalamus itself, are often causes. Now, there are scales for rating the severity. Now, I would never think to say that in the pre-hospital setting you should pull out a card and start calculating the scores to try to judge whether it's most likely a thyroid storm, impending storm, or something else like that. But I think taking a look at this, if you take a moment to look at this scale, it's a good way to kind of show you how some of these play into your assessment. So the higher the fever, the higher the resting tachycardia, if they have atrial fib on top of that, if they have signs of high output congestive heart failure, if they have GI upset or jaundice, etc., if they have delirium, psychosis, the more of these they have, obviously, the more likely it is to actually be a thyroid storm. Does that make sense? So take a moment to look at these, kind of plug these into your brain. And if you couldn't read that, I put this slide on here that that might be a little bit clearer. Like I said, the mortality is fairly high, particularly when you have high output heart failure. That's what most of these patients pass from, is from respiratory failure due to high output heart failure. So how are we going to treat this? Well, obviously, all these patients get vomit, which is vital signs oxygen monitoring, IV fluids, and transport. You're going to cool them if they're feverish, dextrose, antibiotics, and beta blockers. Now, when we talk about fluids and dextrose, again, why every patient or most patients, you're going to get BG on, even if they don't have a history of diabetes. Sometimes we're a little concerned about fluid resuscitation when they are manifesting signs of heart failure, if they have pulmonary edema. But remember, this is high output pulmonary edema, not low output pulmonary edema. So low output pulmonary edema is what you see in the cases of cardiomyopathy, where the heart is so enlarged it can't contract well, or the heart muscle is hypotonic. It doesn't have a lot of strength to it. In this case, you have hypertonic heart. It's beating so fast the ventricles don't fill enough, so you have you have some congestion from a result of that. So by slowing the heart, you can actually solve the problem, but also by supporting preload. Remember, high output heart failure is preload dependent. So a little fluid supports preload. When we talk about blocking thyroid hormones, this is not something we're going to be doing, but maybe on interfacility transports. You may be transporting patients receive this, thyroid blocking hormones. Now, it does not, let me back up. So sometimes you may have to continue this treatment en route, and one of the things you may have to administer is over long transports is Lugol's solution. Lugol's solution is also known as Lugol's iodine, and there's a variation of this used to keep coral clean in home aquariums. But it's an iodine, potassium iodine, and distilled water. It's administered orally. It also helps manage hyperthyroidism as well. The reason why you get antibiotics is twofold. And one of the reasons you're given antibiotics is that distinguishing between sepsis and thyroid storms can be difficult. And they may also exist simultaneously because infection is also often a precipitant for thyroid storm in patients with Graves' disorder. We're also going to give oxygen. We already talked about fluids. If you're going to give vasopressors, say they are hypotensive, but they have high output heart failure, if you're going to get vasopressors, it's going to be norepi. You're not going to give anything that's going to increase the heart rate, but norepi is pure alpha, so that's going to be your go-to. You may actually try to slow the heart rate by beta blockers. And of these three options I'm going to mention right here, beta blockers is best supported in evidence. If they are refractory to beta blockers, or beta blockers are contraindicated, or you don't have the availability of beta blockers, calcium channel blockers may be an option, not a great option, or a cardioversion if they're really unstable. Respiratory support, as we talked about, oxygen, regardless of SATs, because they tend to be anemic, oxygen support is going to be substantial. If they have pulmonary edema, some CPAP as well, or intubation as needed. Now, why beta blockers? Well, again, we're talking about sympathetic surge, which beta blockers are kind of controversial on because they manage heart rate, but they don't manage alpha portion. So propranolol is commonly used. In the pre-hospital setting, some places still carry esmolol. Now, esmolol is a short-acting beta blocker, 50 to 100 micrograms per kilogram per minute as an infusion, or 500 micrograms IV, right? And nice thing is it's short-acting, 5 to 10 minutes or less. So it's one of those things that's usually given by infusion with a loading dose. So it's great for it's actually perfect for high output heart failure. And if it doesn't work, you stop in 5 minutes, its resolution is resolved. So we talk about steroids. Now steroids are kind of weird. We use the same dose for adrenal crisis. Now the reason why we're using steroids is it blocks conversion of T4 to T3, which in turn blocks the release of thyroid hormone. So steroids in this case would give Cymetrol or Cycortef if you carry that, or dexamethasone, 125 250 milligrams IV push. Plasmapheresis is another great option that you'll sometimes see. Plasmapheresis has a bunch of different uses in critical care. In this case, you're doing one of two things. You're either removing plasma that contains elevated levels of thyroid hormone and replacement with saline through the process, or you're removing plasma, filtering out the thyroid hormone, and replacing it. And both options are used. So the overall goal when we talk about thyroid storms and hyperthyroidism is to remove or decrease circulating thyroid hormones, and then manage the adverse effects, which are largely sympathetic surge in nature. And then supportive care and transporting them to ICU level facilities, because that's what they're going to require most likely down the road if they're severe. So thank you for your time, and we'll move on to some of the next discussions here shortly.